Welcome back to Family Planning and Abortion for Medical Students. Today, we will be discussing methods of abortion. We will be covering the below APGO learning objectives regarding methods of termination and potential complications of these procedures. These are covered under Topic 34, Abortion. Our learning objectives for this video, including understanding the two major types of abortion procedures, including how and when they are performed, understanding the possible complications of abortion, understanding why a patient may choose one option over another, and practicing our knowledge with a case. Let's start with a definition. We will be discussing induced abortion, defined as the medical or surgical termination of a pregnancy before the time of fetal viability. This is in comparison to miscarriage, also called spontaneous abortion, which is a pregnancy loss prior to 20 weeks gestation, which we will not be discussing. Induced abortion has been legal in the U.S. since the Supreme Court's decision in 1973 on the case of Roe v. Wade. Since that time, various state and federal laws have made attempts to limit access to abortion services through trap laws, waiting periods, insurance restrictions, and more. This will be discussed in another video. A few notes on the timeline and general principles regarding abortion procedures. Whether or not a procedure can be performed depends on the gestation of the pregnancy. This image on the right is helpful in seeing which options are available for abortion at each week of pregnancy. Generally speaking, as the length of the patient's pregnancy increases, there are less options for procedures. I will not be discussing all of the options in the graphic, but it is a good reference for what is available depending on gestational age. Another important thing to note is the use of ROGAM in abortion. As I'm sure you've learned in your reproductive or hematology courses, pregnant people should be assessed for their Rh status, and Rh-negative patients should be given ROGAM prior to delivery. The same is true for patients choosing a medical or surgical abortion. Another note is that for both types of surgical procedures, antibiotics are given afterwards to prevent infection. This is sometimes done with medical abortion as well, but less common as the infection risk is pretty low. So as stated, the two types of abortion are medical and surgical. We will be splitting these up by talking about both options in the first trimester. We'll start with the medical option. With this method, patients take a drug or a combination of drugs to induce abortion. The three primary medications that have been researched and widely used are methotrexate, mifepristone, and misoprostol. Methotrexate is a folate antagonist. As I'm sure many of you have learned during your reproductive unit, folate or folic acid is crucial in fetal development. Methotrexate's competitive inhibition of folate binding stops growth of the fetus. In the U.S., this is more commonly used to treat ectopic pregnancy than to terminate intrauterine pregnancies. Mifepristone is an anti-progestin, meaning that it blocks progesterone action in the uterus, causing atrophy of the decidua. The lack of nutrition from the decidua, or inner lining of the uterus, causes the blastocyst to die and to detach from the uterus. Misoprostol is a prostaglandin analog that binds to myometrial cells. It mimics the natural job of progesterone in the uterus, which is to stimulate uterine contractions to aid in expelling fetal tissue. Although all three of these drugs have been heavily studied, the typical regimen in the U.S. is a combination of mifepristone and misoprostol, colloquially referred to as the abortion pill. This regimen is indicated for pregnancies up to 10 to 11 weeks of gestation and is not prescribed to patients beyond this gestation. Medication abortion is allowed in the second trimester, but it must be performed in a clinic, so I'll only mention it briefly when we discuss second trimester options. Surgical abortion in the first trimester includes aspiration. This can be performed between 6 and 16 weeks gestation. This is when a dilator is placed in the cervix to create a larger opening and local anesthetic is injected. Once the cervix is dilated, a cannula is inserted into the cervix and suction is applied either manually or hooked up to a vacuum device to remove the products of conception. The procedure is brief, usually around 10 to 15 minutes. Patients can expect to experience cramping during and for a few days after the procedure, as well as a few weeks of irregular bleeding. Patients should take antibiotics and pain relievers afterwards. Now we will discuss second trimester options. As mentioned before, medical abortions in this trimester are not as common as surgical procedures, but are still available to patients. They involve a similar regimen of misoprostol and mifepristone, but at a higher dose. These pills cannot be taken at home, and the patient must be in clinic, gestational age. During the second trimester, after 13 weeks gestation, the surgical option is dilation and evacuation. This is when the cervix is dilated and the products of conception are removed with forceps. Usually, the cervical dilation will be started the day before the procedure with an osmotic dilator to ensure that the opening is large enough to perform the procedure. This dilator is called a laminaria. It is a small tube made of seaweed that opens the cervix over the course of several hours. Patients will generally have this dilator placed 12 to 24 hours before their procedure and leave it in the cervix until the time of their abortion. Before the procedure, a patient may get general anesthesia, spinal anesthesia, or a block and a sedative, depending on the clinic's practices and patient preference. A cannula and forceps are placed into the uterus, and the products of conception are removed. A curved instrument called a curette is then used to scrape the lining of the uterus to ensure all fetal and placental tissues have been removed. This can also be confirmed via ultrasound. Like a first trimester procedure, cramping and bleeding should be expected afterwards, and over-the-counter pain relievers and antibiotics should be used. To summarize, in the first trimester, patients can undergo a medical abortion through a mifepristone and misoprostol regimen or surgical abortion through aspiration. In the second trimester, patients more often undergo surgical abortion through dilation and evacuation, but also have the option of medication abortion in the clinic setting. A last note. Although these procedures are legal for both trimesters across the U.S., legality of abortion is determined by fetal viability, which differs in each state. In some states, you will find no providers that perform abortions over 20 weeks, and in others that will provide abortions into the third trimester, although this is rare. We will talk more about access in the next video. Now let's talk about why a patient would choose one method over another. In both cases, patients can have medical histories or comorbidities that make them better candidates for medication or surgery. Besides that, patients elect for medication abortions for a number of reasons, including not having to be in a doctor's office during the procedure, choosing a location they feel more comfortable in, deciding who gets to be around during the procedure, and a more natural feeling because it is more like a miscarriage and not as invasive as no surgical tools are used. Because second trimester medication abortions are often wanted pregnancies and are the result of fetal anomalies, medication abortion in the second trimester can allow patients to experience labor and see or hold an intact fetus, although this must be done in a medical facility. Patients may elect for surgical abortion for a number of reasons, including wanting to be surrounded by healthcare professionals and/or supportive staff members, as well as the relative speed of the procedure. Patients can walk into clinic, undergo a 10-minute procedure, and no longer be pregnant, compared to up to 24 hours for medication abortions to occur in the first trimester. Similarly, in the second trimester, surgical abortion is the preferred option and is much shorter and slightly safer than medication abortion at the same gestational age. Now let's talk about the complications for these procedures. The most common complications of both types of abortion include uterine perforation, cervical laceration, hemorrhage, incomplete uterine evacuation, and infection. Infection is generally related to incomplete abortion, which is when some of the products of conception remain in the uterus after the procedure. Overall, the rate of major complications is below 0.31% and below 5% for minor complications, and the overall mortality associated with abortions is 0.6 patients out of 100,000. So let's practice with a case. Emma is a 22-year-old G1 P0 with no significant past medical history presenting to your clinic with a confirmed positive pregnancy test at 6 weeks gestation per her last menstrual period that is considering an abortion. What are her options? You can pause now to think about it or go back and review some of the previous slides. So Emma is 8 weeks pregnant. This puts her in the first trimester of pregnancy. She can have a medication abortion that can be done at home or in another place she feels comfortable, or if she wants to treat this surgically, an aspiration procedure in an outpatient clinic. After fully discussing and counseling Emma on her options for continuing the pregnancy versus the 2 types of abortion procedures, Emma states that she wants an abortion and wants the procedure to be over as quickly as possible. She is also nervous about complications. What would you tell her? So we can tell Emma that surgical abortions are usually a quicker procedure and can be done in less than a half an hour, whereas medical abortions are slower and can take up to 24 hours to completely pass the products of conception. We can tell her that the most common complications she could experience and reassure her that whichever procedure she chooses is safe and has low rates of major complications and mortality. Thank you for listening to this extremely important topic. Please check out the resources for more information, as well as patient-friendly materials, and tune into the next video to learn more about the public health impact of the legal status of abortion in the state of Roe v. Wade.